Unfortunately, it's hard to start to talk with unfortunately, this is going to be the most difficult talk you ever hear in your adult life. And the only way to remember anything at all is to only remember some of it. Okay. So my task this afternoon, is to help you understand and identify what are those few things that you need to remember. Okay. Because clearly, the expanse of the topic is so broad that it will be impossible to really understand this clearly. The problem, though, has multiple layers. First of all, medication affects sleep in many ways. It can be a direct effect, or it could be an adverse consequence. It could be a common reaction, or it could be idiosyncratic. It could be from use of the medication or from withdrawal of the medication. Okay? And then finally, most importantly, you can have multiple medications that act differently, independently of each other, all of them working on the same patient. Okay? So it becomes rather complex. When you look at sleep and you define it, it's quite simple. There is behavioral quiet, they're quiet behaviorally, and there's diminished response to stimuli. But that state can also be seen in other conditions, right? Daydreaming, anesthetics, inebriation, coma, catatonia. Everything that I mentioned has behavioral quietness and diminished responsiveness. What makes sleep unique? What makes sleep unique is that unique features of certain transmitters in the brain, okay, located in very specific areas of the brain, and we have to explore that, unfortunately. So let me show you the complexity of wakefulness. There are multiple transmitters that are each contributing to wakefulness. Each of the neurons has different parts within the brain. Okay. Now, I do not want you to memorize this. But what I want you to know is that these transmitters are redundant in that any injury to any one cell or any one transmitter will not completely abolish wakefulness. Okay. Secondly, is that these transmitters, although all of them generating wakefulness to a certain degree, have different effects on wakefulness. For example, if you look at motor activation during wakefulness, then that probably is in the area more of dopamine and acetylcholine. Again, don't memorize this, I just want to explain to you some of the concepts. When we talk about alertness and attention, okay, then you talk about histamine, norepinephrine, and acetylcholine again. And for emotional arousal, you have dopamine, norepinephrine, serotonin. So again, these transmitters, although they all subserve wakefulness, okay, really are responsible for different components of what we call wakefulness: motor activation, alertness, and emotional arousal. Let's look at some examples of these transmitters in play. Dopamine is a wake-promoting agent. So therefore, any agent, any medication that increases dopamine, such as amphetamine, will increase wakefulness. Okay. On the other hand, anything that antagonizes dopamine, such as haloperidol, will promote sleep. Okay. So a very simple concept. You have a wake-promoting agent. Okay. Is this better or is this better here? This one here? Okay. So you have one agent that promotes wakefulness. So therefore, any medication increases dopamine will increase wakefulness. Amphetamine is an example. And any agent that promotes or antagonizes dopamine will promote sleep, such as haloperidol. The same concept extends to histamine. Okay? We know histamine is a wake-promoting agent. So therefore, antihistamines, okay, such as diphenhydramine, will cause sedation. Catecholamine, again, is a wake-promoting agent. So anything that can increase levels of catecholamine, such as isoproterenol, will also increase arousal and wakefulness. Okay, very simple concept. Okay. Stimulants, okay, well, they differ. So, for example, amphetamines, cocaine, and methylphenidate or Ritalin promote wakefulness by increasing dopamine and norepinephrine. Okay. Modafinil and armodafinil increase wakefulness by increasing hypercretin dopamine. By the way, modafinil also decreases a sleep-promoting agent, which I'll discuss later on. So the concept is very clear. If you have an agent that increases wake-promoting substances, then it increases wakefulness. So these are the systems, on the other hand, that generate sleep. GABA, adenosine, glycine, acetylcholine. Again, do not memorize this, nor memorize the neurons. However, what I would like you to remember, though, is that the same argument exists for the sleep transmitters. GABA is a sleep-promoting agent, so therefore anything that increases GABA-A, for example, benzodiazepines, will cause sleepiness. Okay. Indeed, alcohol, which we all know, if used at high dosages, can be sedating, facilitates GABA. But at the same time, it inhibits a wake-promoting agent called glutamate. Okay. So alcohol has that effect too. Adenosine is a sleep-promoting agent. So therefore, when you drink caffeine, you become more alert. You're really blocking the receptors for adenosine. Acetylcholine promotes REM sleep. Any agent such as physostigmine that increases acetylcholine will therefore enhance REM sleep. And any agent such as antidepressants that antagonizes acetylcholine will decrease REM sleep. Okay, again, don't memorize this. I just want to explain to you the principles behind this. Okay. Let's take, for example, GABA. GABA is a very well-known agent. It has a receptor that has many subunits. And these subunits subserve different functions. Some of them are hypnotic, some of them are anxiolytic, some of them are muscle relaxants, some of them are anticonvulsants. So if you have an agent such as benzodiazepines, okay, that has affinity to all of these subunits, for example, benzodiazepines have affinity to alpha 1, 2, 3, and 5. Okay. Valium, for example, diazepam. Okay. If you give diazepam, you give it because of its myorelaxant properties. You give it because of its anticonvulsant properties, anxiolytic properties, and hypnotic properties. If you give a Valium, for example, somebody with muscle spasms, or somebody who has status epilepticus, or somebody who is highly anxious or has insomnia, right? So it has widespread effects on all of this. On the other hand, the more commonly used drugs now, such as zolpidem and azopiclone, are more selective. Okay? They target not all of this, but certain subgroups only. Let's take the case, for example, of zolpidem. Okay, zolpidem is a pure hypnotic agent. It has very, very minimal anxiolytic, almost non-existent myorelaxant, and no anticonvulsant effects. So somebody who takes zolpidem, for example, will tell you that once they take the agent, nothing happens. They don't get any more sedated. They don't get any more sleepy. They don't get any less anxious. They just wait. And then suddenly they fall asleep. Okay. It's a hypnotic effect. And that may explain some of the things that you hear in the newspapers of people who sleep drive, people who sleepwalk, or people who sleep eat, okay, or have sleep sex while taking zolpidem. Although the matter is rather complex, okay, imagine somebody who takes zolpidem and trying to fall asleep, and then nothing happens, and decided after 15 minutes, I'm going to cook, right? or I'm going to drive, or where's my spouse? Let's do something together, and then they fall asleep, right? Because they have no muscle relaxant and no sedative effects. They are sedating as a whole, okay, and as a class, they decrease N3 sleep and REM sleep. Okay. So this is something very important to remember. So although they may fall asleep more rapidly, okay, the sleep architecture of somebody who takes these agents are not quite as similar as that of natural sleep. And because they decrease REM sleep, okay, with drug withdrawal, especially with acute drug withdrawal, you will have REM sleep rebound. More commonly, they will present with nightmares. In the susceptible adult, they may even present with REM sleep behavior disorder. Okay. Adenosine is another sleep-promoting agent. What it does is quite fascinating. Whenever there is activation of cells, okay, in the brain called astrocytes, they break down ATP, which is the source of energy. Okay? And this breakdown of ATP is what they use as the substrate for adenosine. So for example, if I were to stand here before you whole day, okay, and simply move my left hand, okay, because my left hand is controlled by my right motor cortex. Okay. At night, when I fall asleep and you measure the adenosine in my brain, the right motor cortex of my brain will have more adenosine than the left motor cortex of my brain. Okay. So not only do you have global sleep as a concept, you also have regional local sleep. Now what happens with adenosine being increased is that adenosine itself really has no receptors. What it does, it either inhibits the wake-promoting substances, hypocretin, histamine, okay, or it activates GABA. Okay. Again, like I said, there are interactions between all of these chemicals that one has to remember. In short, if I can summarize what we've discussed so far, you have aminergic transmitters, in particular norepinephrine, serotonin, and histamine. A good way to remember that is N, norepinephrine, serotonin, S, histamine, H. Never sleep when hungry, okay? Or if you're younger, never sleep when horny. They are increased during wake. Cholinergic is acetylcholine. They are also increased during wake. Okay? So they're both increased during wake, and during non-REM sleep, both of them are decreased. Okay? And during REM sleep, the aminergic remains low, but your cholinergic goes up. Okay? So that is the major difference between all three. And we use that concept when we talk about wake, non-REM, and REM. Those are the three states of existence: wake, non-REM, and REM. One has to be very careful though when I talk about states, because when you talk about states, the concept that most of us have is that this is more like a light switch. We go from wake and sleep, or we go from REM and non-REM. Okay? I think that's a wrong concept. I think the idea should be more like a gate. Okay? A gate that opens between wake and sleep, for example, or between non-REM and REM. So in most patients, most of the time, this gate is very efficient and opens and closes rapidly and completely. However, there are some instances wherein this gate may be dysfunctional. Okay? They may either be too slow to close or close only partly. Let me give you an example. Cataplexy, okay, is loss of muscle tone during moments of or precipitated by emotion. Okay? That could be visualized as elements of REM penetrating into wakefulness, right? On the other hand, REM sleep behavior disorder can be thought of as elements of wakefulness that somehow occurs during REM. Same thing with sleepwalking and sleep terrors. You have elements of both non-REM and wake occurring. And then you have the overlap syndrome of nightmares and RBD occurring because there's an overlap between non-REM and REM sleep. So there are elements of each state that can manifest in another. Okay? But to switch from one to another is what's crucial. Okay? And because there are three states, REM, non-REM, and wakefulness, there are indeed three switches that you need to understand. The first is very simple. It's a switch or the gate that occurs between wake on one hand and sleep. What makes you wake up and what makes you fall asleep? In its most simplified version, it is nothing more than GABA on the one hand, GABA which is your your sleep promoting agent, okay, versus your never sleep when hungry, norepinephrine, serotonin, histamine. Typically there is a bidirectional inhibitory, so one inhibits the other, okay, and this interaction is constant. Whenever GABA, okay, predominates over norepinephrine, serotonin, histamine, sleep occurs. It's as simple as that. Okay. So at any one time now, in this audience right now, your GABA on one hand and never sleep when hungry is competing to make you sleepier. Okay? And I am here trying to make your GABA less powerful. Okay. So this is the first switch. The second switch is between non-REM on one hand and wake and REM on the other. Now why is this important? Because if you look at the EEG of wake and REM on the one hand and non-REM on the other hand, you will see a very distinct difference. In wake and REM, because really of acetylcholine, you have depolarization or excitation of cortical neurons. Okay? So neurons between the cortex and the thalamus fire rapidly. Okay? And this firing is seen during quiet wakefulness as alpha, and during REM sleep as theta. Okay. Now theta and alpha waves, like you know, they are low frequency, rapid oscillating waves. Okay. These are depolarized, these are excited waves. On the other hand, non-REM occurs when GABA, okay, the powerful GABA, eliminates acetylcholine, causing hyperpolarization. When they're hyperpolarized, they're inhibited, so they slow down and become delta waves. Okay. So the interaction now between acetylcholine and GABA is what creates this thalamocortical switch between non-REM on one hand and REM and wake on the other. Good. We have one switch left. The REM on and off. Okay. So what switches between non-REM and REM is really very simple too. We have REM on neurons, acetylcholine being one of them, okay, and REM off neurons. Again, you're aminergic, never sleep when hungry. What happens now is that whenever you have REM off neurons occurring, you turn off REM. Okay, this is your never sleep when hungry. Non-REM occurs. And when your REM on neurons, your acetylcholine kicks in, REM occurs. Okay? So really, REM occurs only when you have the REM on neurons turning on and the REM off neurons turning off. Very simple. Okay? So, let's look at the transmitters again that I told you not to memorize. Now, hopefully, things will be clear. Acetylcholine and glutamate, by the way, I'll explain shortly, are present during both wake and REM, and they are absent during non-REM sleep. Histamine, norepinephrine, serotonin, and hypocretin are present during wake. They're absent during non-REM and REM. Okay. Then finally, GABA, okay, which is sleep-promoting agent, is present during non-REM and REM, and absent during wake. Okay, so this whole thing makes sense if we look at the three switches. Now let me talk briefly about glutamate. Glutamate is the main excitatory transmitter. Okay. A student of mine told me this mnemonic, which I would like to share with you. Again, it's not my mnemonic. He says it's excitatory, so going to mate is exciting. That was his mnemonic for me, and I said, well, fine, going to mate is exciting. But what's important is that glutamate is found in the ascending reticular formation. Okay, and what he told me too, he says, so anything that gets excited ascends. I said, what? What do you mean by that? I can't tell it in an audience like this. I'll be. No, he said, no, look at the stock market. Okay, if it gets excited, it ascends. Okay, so I think that's a better concept to think of than the one that has a sexual connotation. So, those of you who remember Lord of the Rings, let me just rephrase it a bit. You have 9 transmitters to form the stages, 3 switches to control the changes, 1 brain to rule them all, in the land of slumber where the shadows lie. Okay? That's the easy part. Let's go to the hard part now. What causes waking? So you have this ascending reticular formation, which I mentioned earlier, is glutaminergic. Okay, and you have inputs from norepinephrine, serotonin, histamine, dopamine, and acetylcholine. Okay, there are 2 pathways for this ascending reticular formation. From the reticular formation to the cortex, there are 2 pathways. One is the thalamus, which is the dorsal direct pathway, and there's another pathway down in the ventral path of the brain called the ventral pathway through the hypothalamus and forebrain. Okay? Now, what are this? So here you are. You have the ascending reticular formation going from reticular formation to the cortex. Okay? Reticular formation here, if I get my arrow, to the cortex. You have 2 pathways. One direct dorsal, directly up here through the thalamus. And you have one ventral pathway circular to the basal forebrain and hypothalamus up again to the cortex. Okay? So these are 2 pathways of the ascending reticular formation. Why is this so important? Because if we look at this very carefully, you have inputs from norepinephrine, serotonin, you have histamine, hypercretin here, all of them inputting into the system. Okay? So, hypercretin neurons are wake promoting. It has 2 important effects. It has a direct effect on the cortex stimulating wakefulness. It also has an effect downstream, locus coeruleus, which is your norepinephrine, dorsal raphe, your dopamine, tubermammary nuclei, which is your histamine. It also stimulates them. So it has a direct effect on the cortex stimulating wakefulness. It also affects all the other wake promoting agents. This is important when we talk about narcolepsy. Okay, this is very important. So when you regulate sleep, you have GABA promoting both non-REM and REM, and you have your acetylcholine promoting REM sleep. GABA is found in the ventrolateral preoptic neuron, VLPO, while REM neurons are found in the PPT-LDT, pediculopontine tegmentum, lateral dorsal tegmentum. Okay. Don't need to memorize this. What I need to tell you though is this. The VLPO, which is where you have your GABA neurons, is active during REM and non-REM sleep. And what it does very well, is it inhibits this wake promoting agent I showed you earlier. Okay. It inhibits hypercretin, acetylcholine, norepinephrine, serotonin, histamine. So in this picture we show it. So you have the VLPO here. Remember the pathway earlier where you have ascending reticular formation up to the cortex, either dorsal or ventral? The VLPO is right smack in the middle of there. Okay? And what the VLPO does, okay, it inhibits all of the other transmitters that you find here that are wake promoting. That's what it does. Again, what the VLPO does, it projects to inhibits all the wake promoting agents. Remember my very first slide when I talk about wake and sleep switch and the balance between GABA on one hand and never sleep when hungry? That's what happens. So when you go and fall asleep, your GABA influence through the VLPO here, okay, balances out your never sleep when hungry. Okay. What about the acetylcholine REM promoting LDT PPT? I also told you earlier that there's a REM on and REM off switch. That the REM on switch is acetylcholine found again in the LDT PPT. Then you have the REM off neurons. You'll never sleep when hungry. So the REM on neurons are really inhibited by the never sleep when hungry. So any agent that increases any of this, okay, serotonin, norepinephrine, will suppress REM sleep. So let's explore that concept a bit. Hypercretin, I mentioned to you earlier, activates the cortex directly, but also indirectly goes down and activates serotonin and norepinephrine. Remember I told you locus coeruleus and dorsal raphe. So hypercretin, okay, really suppresses REM sleep. So when you don't have hypercretin, and where do you find that state? When there's a lack of hypercretin neurons, find that in narcolepsy. What do you have in narcolepsy? You have massive REM pressure, right? You have REM pressure causing, for example, cataplexy, sleepiness, paralysis, and hallucinations. And how do you treat the cataplexy of narcolepsy? You give them antidepressant. And what do? They increase serotonin. Okay, so this concept of balance between the REM off and REM on neurons are very, very important. Okay. There's another thing too about acetylcholine and PPT-LDT. These REM cells has two effects. One, it ascends into the thalamocortical neurons, okay, causing this theta waves. Okay. Recall when I showed you the switch between non-REM and wake REM, okay, I said that acetylcholine will cause depolarization, okay, and causing this very rapid low frequency waves. That is because the LDT PPT neurons goes up into the cortex. But the LDT PPT neurons also goes down into the spinal cord, okay, causing muscle atonia, which is also characteristic of REM sleep. So in REM sleep, what do you have? You have theta waves that you see. You also have muscle paralysis, and that is due to the LDT PPT neurons subserving acetylcholine. Okay. Now, with that background, let's explore some of the drugs. Okay. And let's look at stimulants, antidepressants, opioids, cocaine, and alcohol. Okay. These are just some examples. I'm not going to talk about beta blockers. I'm not going to talk about anti-seizure medications. But this will give you an idea of what those transmitters are doing in very specific states. Let's look at stimulants. Stimulants, by their very name, is alerting. So taken acutely, it will increase the time it takes for you to fall asleep, and it will decrease total sleep time. Okay? But stimulants also, because of their nature, would decrease N3 and REM sleep. Okay? So what happens when you take them? You'll be alert, but also you will have less sleep. Because of this, when you stop taking it, when you withdraw from stimulants, what happens? Everything reverses. So your sleep latency now goes down, you become sleepy, you sleep longer. You also have REM rebound. Okay? So people who take stimulants and suddenly stop taking it will become sleepy, and will have REM rebound, in some instances manifesting as nightmares or REM sleep behavior disorder. I had discussed this very briefly earlier when I said that amphetamine, cocaine, methylphenidate works by increasing dopamine and norepinephrine. I also said that modafinil and armodafinil increases hypercretin and dopamine and histamine. And I also alluded to briefly that it can also lower GABA. This we already discussed, caffeine increasing adenosine and nicotine increasing acetylcholine. It used to be that people do not smoke when they are asleep, okay, and they still don't. But what nicotine can they absorb during sleep? What? Right. So a patch is supposed to be removed when you go to bed. Okay. But a lot of people have this urge, craving to smoke when they wake up in the middle of the night. So some of them think that maybe they keep the patch on. Okay. And who among you have had patients who kept the patch on during the night? Does anyone? And what did they ever describe anything to you? What? Dreams and nightmares. Dreams and nightmares. Very common. Why? Because of the increase in acetylcholine because of REM sleep. Okay. Now, I also mentioned to you earlier that different elements of wakefulness, okay, such as motor arousal, emotional arousal, alertness, have different chemicals. Okay. So one has to realize too that the effects of amphetamine on one hand and modafinil are slightly different. Okay, slightly different because of differing effects on emotional arousal, alertness, and motor activity. Okay, so they're very different. Okay. Antidepressants. They are, as a whole, REM sleep suppressants. As a whole. Okay. In fact, if you look at the old agents such as the monoamine oxidase inhibitors, they are the most potent REM inhibitors. Monoamine. Remember the term we used before? Aminergic agents, norepinephrine, serotonin, histamine. Okay. By inhibiting them, okay, remember they are monoamine oxidase inhibitors. So they inhibit the breakdown of these agents, they increase them. They are very, very potent REM inhibitors. And sudden withdrawal of these agents, again, will cause nightmares and sometimes even RPP. Opioids are sedating. Again, look at this. They decrease N3 in REM sleep. Most agents, by the way, I have to tell you, decrease N3 in REM sleep. Opioids may worsen sleep apnea because of its muscle relaxant effect, but also be known to improve symptoms of restless leg syndrome. Okay. And during withdrawal, okay, withdrawal can cause insomnia and nightmares for the very same reason we talked about here earlier. Okay. Cocaine. Cocaine increases catecholamine. It is a psychostimulant. Okay. And like other stimulants, it will decrease total sleep time. It will also decrease REM sleep. Again, it's a very commonly used agent, and because of its half-life, withdrawal can occur during the night. Therefore, they can cause REM rebound in the second half of the evening with nightmares and RPP. Alcohol. There's a funny effect on alcohol. It's really biphasic. So imagine somebody in a bar who just entered, okay, and drinking his first beer, and imagine this person really quite eloquent, okay, quite happy, engaged, because at lower dosages and on the rising phase of alcohol, it's stimulating. Okay. However, imagine the same person at the end of the evening driving home, because at high dosages and on the falling phase of alcohol, it is sedating. Right? You see this effect. When you're starting to drink alcohol, you're quite engaged. When you're drunk, you're sedated. Okay. Alcohol has that effect as well. When you use alcohol on the first part of the evening, because it is sedating, they sleep well. It takes them a short time to fall asleep. In fact, they have increased N3 sleep and at the same time decreased REM sleep. Okay. There are a few drugs, by the way, that increase N3 sleep. Now, N3 is extremely important. I'm not saying that you should take alcohol, by the way. I'm saying N3 is extremely important because N3, we believe now, is the stage wherein short-term memory is transmitted into long-term storage. Now, let me explain that a bit. There is enough compelling data now to suggest that short-term memory is it's limited. There's only a few things we can keep in short-term memory. On the other hand, long-term memory is, we think, infinite in storage. But it takes time for your short-term memory to be transported in long-term memory. We think that occurs during N3 sleep. And we think that occurs during packets of information. It's not a continuous transfer. It's really in packets. Why do we think this is the case? Because any sleep that's shorter or longer than the packet would eliminate transfer of memory. So imagine a film going through, okay, or maybe a conveyor belt going through, and here you are picking a short-term memory, putting it there to be transported to long-term memory. So you have to have a certain amount of memory being transported and having enough blocks of non-REM sleep for that to be transported through. So anything that increases N3 duration, anything that consolidates N3 sleep, or imagine this, anything that can increase N3 intensity, okay, will improve memory. So theoretically, if you have a substance or a device that can enhance N3 sleep tremendously, okay, you will have tremendous memory recall and performance the next day, even if you are sleep deprived. Okay. So the next step to human evolution, we are going to remain as a species and sleep less and less, okay, is to enhance N3 sleep. Okay. And there's intriguing data coming out now among neurophysiologists, among animal model researchers, okay, and among psychotherapists, that measures to improve N3 sleep has such an effect. Okay, that it does improve memory, it does improve recall, it does improve daytime performance and daytime alertness. But that's a detour we won't take. So alcohol, if you use it in the first half of the evening, increase N3 sleep. In the second half, because alcohol gets metabolized, now you have decreased N3 and a REM rebound. Okay. So what happens? When you use alcohol, there are a few things that happens during the course of the evening. There is a higher risk for bedwetting, restless legs, sleep terrors, sleepwalking, snoring, and of course sleep apnea. Okay. And because of the REM rebound that occurs in the second half of the evening, when alcohol gets metabolized, you have nightmares and vivid dreaming really reported by these patients. Okay. And they're quite common. Indeed, if you have an adult who has RBD, one of the few things you should not forget to ask is alcohol. Okay. Because alcohol use at bedtime, okay, is one of the main triggers for RBD. Withdrawal of alcohol, okay, can cause insomnia, frequent awakenings, vivid dreams during REM rebound. The problem with withdrawal is that this effect can last years. Okay, so it's not during the acute withdrawal phase that this happens. This can happen also throughout the long recovery period, as well as during long-term alcohol cessation. I'm going to end my talk with control of sleep and waking. So sleep and waking is really controlled by two processes. Okay. One is sleep homeostasis. It's nothing more than sleep pressure. So the longer you are awake, the sleepier you become, and the longer you are asleep, the less sleepy you become. Okay. So if that were true, and if that was the only thing that was true, everyone here should be sleepier by 40 minutes now than when I started. Okay? And hopefully you're not. And because if you're not, it's not because of me, it's because of your circadian rhythm. Okay? At the same time that you're becoming sleepier because you're awake, your circadian influence is promoting wakefulness. Okay? So here you are. During the waking period, hopefully, as your sleep pressure increases, causing you to become sleepier, your circadian pressure also increases, causing you to be alert. Okay? So both pressures here will maintain constant alertness during the waking period. Again, like I said, if you are asleep, the longer you are asleep, the less sleepy you become, so the more prone you are to waking. But that doesn't happen because during sleep, as you're having a falling sleep pressure, at the same time, you're having a falling circadian alertness pressure. So during the daytime, this balances out, you remain awake, and during the night, this balances out for you to remain asleep. There is a concept in circadian science called phase. Okay? So phase is nothing more than your cycle, which is your sleep-wake cycle, in relation to the external time. Okay? So if you go to bed earlier and wake up earlier than desired by society, you have something called phase advancement. If you go to bed later, such as a teenager, going to bed at 4 in the morning, and you wake up later, such as a teenager wakes up at noon, you have a phase delay. Okay? Now, this is very important because there are agents out there that can reset your phase advancement or phase delay. One of them is light therapy. Okay? So light therapy is a very powerful Zeitgeber that can alter the phase of the sleep-wake cycle. If you give, let's say a person's bedtime is advanced. Okay, let's say they go to bed rather early. Okay, if you give light therapy at night, okay, it will phase delay sleep period. Okay. So think of this: phototherapy, which is light, pushing sleep away from it. Okay. On the other hand, you have melatonin. Melatonin, which is synthesized in the pineal gland, okay, works on the other direction. If we give melatonin, let's say at night here, okay, what it will do, it will attract your sleep-wake rhythm towards it, causing a phase advancement. So melatonin, M, is a magnet that's pulling sleep towards it. Okay, so concept is clear. Light pushes, melatonin attracts. Okay, so here we are. Here you have a patient who has delayed sleep phase. This is a teenager. Okay, so this is actigraphy. Actigraphy measures activity, which we think is wakefulness, and then no activity, which is either rest or sleep. So in this case, over several days, you see a very clear pattern of sleep between 4 a.m. and noon, okay, which is good in the summer, but when school starts, this is inappropriate. So how do you treat it? You want the patient to go to bed earlier, and you want the patient to wake up earlier. So you give melatonin at night and lay light in the daytime. This pushes, this pulls. Okay. What's this? This is somebody who probably is an older adult, okay, who may be living alone or in a nursing home, who sleeps early and wakes up equally early. So this person is asleep now at 8 p.m. and waking up at 2 a.m. Okay, therefore complaining of nighttime hypersomnolence and complaining of early morning awakenings. What you can do here, you can give light, okay, to push the bedtime. Now what's clearly missing here is melatonin, right? Why can I use melatonin here to pull it as well? Why? Two reasons. Melatonin is also a hypnotic agent, although mild hypnotic agent. You do not want to give somebody melatonin in the daytime to pull it when they could be falling asleep with that, kind of dangerous. Secondly, melatonin production is suppressed by light. Okay? So if we give melatonin here and it's daylight, okay, it doesn't have much of an effect. So unlike delayed sleep phase syndrome where you can give light and melatonin, in advanced sleep phase syndrome, really the only effective way to counteract this is by giving light at night. Okay. So in summary, sleep and waking are rather complex entities. They are interrelated, they are regulated, and they are synchronized to a degree that all of us don't have to think of wake and sleep. It just happens naturally. Okay, and that's the wonder of it. Okay. But underneath this simplicity is a very intricate system of transmitters using different neurons acting in different switches. Okay. Now the switches, like I said, are not gates that are open and closed all the time. They can be partly open and partly closed, and they can be deficient. Okay? And because of this, agents, when you think about agents causing effect on sleep, whether they cause alertness or sedation or sleep apnea or restless legs or snoring or nightmares, they have to be considered in relationship to the patient, because the patient is very different from person to person. Okay. At the end, whatever drug you use, I think you should ask the patient how it is affecting their sleep, okay, and change the dose or change the medication accordingly. Thank you. Is everybody confused now? Yes?
This might confuse things even further, but I'm wondering if you could comment on the mechanism of action of that new soon-to-be released sleep aid, emergency sleep aid.
Yeah. So it is a orexin agonist. Okay. Orexin, like you know, is hypocretin. It's a different name for hypocretin. And hypocretin, like I said earlier, is a wake-promoting agent. Affects both the cortex and affects by stimulating never sleep when hungry. So it is one of many agents that will be released pretty soon. Okay. So another agent that you might be familiar with. Okay, we talk about antihistamine causing sedation. There's also agents using histamine agonists, okay, that can promote wakefulness. Again, all of these things are being developed, and as to whether any of them will have significant side effects or not is what will determine whether they get into the market. Yes, sir. Okay, so melatonin has two effects. It has a probably rather weak hypnotic effect, okay, and it's also a very powerful Zeitgeber. It can delay advance or delay sleep phase. So when you have a delayed sleep phase patient, meaning patient sleeps late and wakes up late, you would like to give melatonin as early as possible in the evening for it to attract. For example, the bedtime is 12 midnight. Giving melatonin at 12 midnight, that's nothing, right? So you want to give them as early in the evening as possible for it to become an attractant. However, like I said, it is also a hypnotic agent. So you do not want to give somebody melatonin at 7 in the evening at high dosages for them to become sleepy and create a question of safety for them. So what you do is give them early enough in the evening. I give them very early. I give them right after dinner, and I give them a small dose. That's it. Half of anything you buy in the market. No, actually, the problem is that, and this is something that Max Herskowitz studied, is that many of the melatonin products out there, if you look at the chemical structure, it's not melatonin. Okay, they have Benadryl, they have everything else. So whatever you find, so first of all, find a good pharmacy, okay, so that you know that it's a good melatonin, and whatever it is, cut it by half. So what were you saying?
I would just start with half a milligram.
Yeah.
Half a milligram of melatonin at 6 p.m. is the kind of thing I normally start with. This came up in the break, and someone asked me about the beta blockers. Are you going to make comments about that?
Beta blockers?
Since you talk about melatonin?
There are many types of beta blockers, so it's very difficult. Okay, so there are beta blockers that have a central component with an effect. Okay, among them being propranolol, for example. Okay, and there are beta blockers that have less central effect. The new age, metoprolol, for example. So the ones that have an effect on the central component of the brain truly affects. So beta block, you block the beta sympathetic system. Okay, so the sympathetic tone has many components, among which, of course, is norepinephrine. Okay, but it has also a cholinergic effect too. Okay, so when you use something such as propranolol, it can create quite a few sleep problems, including insomnia and including nightmares too.
I guess I wanted to emphasize that the secretion of melatonin by pineal gland is under the signal transduction system of the sympathetic nervous system. So some of the beta blockers that are lipophilic and cross the blood-brain barrier will inhibit melatonin secretion and therefore can potentiate insomnia. This may be important in patients with hypertension, patients with congestive heart failure, who may be given different kinds of beta blockers. So we have to look at the kind of beta blockers they're getting. For example, carvedilol does not inhibit melatonin secretion, so that's a good beta blocker that I would think is a good one. Right.
So giving melatonin to somebody who takes Indorol, for example, propranolol, doesn't work. Do I find increased need for dosing over time? Depending on what you're using it. If you're using it for circadian rhythm readjustment, no. If you're using it for insomnia, like any other insomnia drug, which I didn't allude to right now, the problem with insomnia drug of any class, benzos, zolpidem, melatonin agonists, is that you're not treating the insomnia. Okay? You're merely allowing patients to sleep despite insomnia. So over time, three things will happen. First of all, the insomnia will get worse if left untreated, so therefore your dose that worked before will no longer work. Secondly, there are some drugs truly, like the benzodiazepines, that can develop tolerance over time. Okay, so you need a higher dose over time. Okay, and thirdly, what was studies from UPenn coming out is that there is significant night-to-night variability, and that the character of insomnia may change over time. So that may also affect the way you dose and you choose your agents for insomnia. Again, I'm sorry.
Sorry. So I found it really fascinating about what you said in regards to the slow wave sleep and how it affects memory and quality of memory. I was hoping you might be able to comment on what you understand about the differences of REM sleep.
Okay. So the question is, what is the role for non-REM N3 sleep, and what's the role for REM sleep in terms of memory and cognition and everything else? I'll try to simplify it as much as I can. Okay. So like I said, when I say memory, there are many types of memory. There's cognitive memory, and emotional memory. Okay. Those are very different. Okay. For example, if I were to have a maze, a rat model maze, and somehow in the middle of the maze there is a puff of air, okay, that will injure the mice. Okay. The mice that is doing that, the mouse, okay, will learn, so that at the end of the experiment, that mouse will try to avoid that particular area. Okay. So that's a memory that is learned during that particular day. If I were to somehow eliminate N3 sleep, okay, in that particular mouse, the next day, lo and behold, the mouse will still go there. Okay. So we know that because that's a transfer of short-term memory down that day to long-term storage. However, if we were to eliminate REM sleep alone, okay, and allow memory to be transported, okay, the rat, okay, will actually go there, not knowing what it is, but become more fearful. It's a strange thing. So there is some emotional memory being transmitted too. Okay. So what we think is happening in REM sleep, again, this is very highly simplified, is that whatever memory now is converted to long-term storage in N3 sleep is however being manipulated, okay, being manipulated during REM sleep to become a consistent memory. So that's where random thoughts, okay, is formalized into a story. Okay. Yes. So.
I guess the other side of this is that also animal experimentation, the animals that were deprived of REM sleep develop hyperesthesia and they become more pain sensitive as well. So there are really, it's a very complicated situation and different domains of different things where the sleep architecture is disturbed, mostly based on animal experimentation.
Yes, sir.
Given that, and antidepressants, mental REM sleep, how come they work with antidepressants? Sounds to me like they make you have a work off.
And there are some patients who have that rage. Okay? So again, it's a balance. Like I said, there's no chemical itself that completely abolishes or really controls one sleep stage. Okay? Having said that, let me give you one example, and hopefully this will be something that will be meaningful to everyone here. There are experiments going on right now using an agent that alters N3 sleep, okay, in kids who have cognitive dysfunction. And when I say that, I mean, for example, Down syndrome. Okay. And using those agents, which we now have in the market actually, okay, within a period of about 6 to 12 months, okay, these kids have been transformed from being homebound, high maintenance patients to people living in a community and doing some work on their own. If this can occur with Down syndrome patients, and we've seen that also, by the way, with other mental states of deficiency. I mean, this is just controlling N3 sleep, nothing else but N3 sleep. Imagine what it will do. Yes, sir.
Sure. Loss of memory, yeah. You get meditated loss of
You know, the problem is that we do know that as we get older, the risk of dementia increases. And we know that as we get older, our ability to generate N3 sleep is all diminished. But I don't think there's a direct correlation between the two. Meaning that if you have N3 sleep more, that you're going to be less risk for dementia. I don't think that's the case. Having said that, however, now again, this is very preliminary work and it's hard for me to explain. So when we talk about sleep, we've always been told that there is the importance of sleep duration, how long we sleep, the importance of sleep quality, how well we sleep, sleep consolidation, how long we stay asleep, okay, and sleep timing. So when I say sleep timing, even if you slept 8 hours, but you're a shift worker, sleeping in the daytime, it is not quite as good as sleeping at night. Sleep consolidation, if you slept 8 hours in a 24-hour period, but separated by 3 hours, so 1 hour sleep, 2 hours awake, 1 hour sleep, it's 8 hours overall, still not quite as good. There's increasing evidence now that there's a fifth component that is not part of our natural brain processes, and that's called sleep intensity. If you were, for example, to measure N3 sleep, the delta weight, okay, not as a percentage of sleep, but as the amplitude of the N3 sleep. Okay? So if you could manipulate delta wave by stimulating the wave at a particular vulnerable point, therefore increasing the wave intensity, the amplitude of the wave, okay, you actually increase something called sleep intensity. That is what we're talking about when we talk about augmenting cognition. We're not increasing N3 sleep. We're not making N3 sleep, let's say, from 25% to 50%. It's still 25%. There's no way we can change that. Human nature doesn't allow us to do that. But what we can do is, instead of having, let's say, a 75 microvolt amplitude, we can make that 100, okay, make the slope steeper. That's what we're seeing right now in those studies. Yes, sir. I'm sorry, sir?
Does gabapentin affect that?
Yes, it does. Gabapentin is one of the few agents that increases N3 sleep. So, as well as sodium oxybate, perhaps even mirtazapine, maybe even trazodone to some patients. Yes, it does. What's Seroquel? What's generic Seroquel? No, what's Seroquel's generic? What? It does. That's right.
I have a question for you. Do you have any concern about these agents that actually affect N3, that in the long run, because growth hormone secretion is associated with N3, that if you keep doing this and keep secreting growth hormone, do you have any concerns about that?
Yeah. So the question is that, N3 sleep is linked with growth hormone release. Okay? So therefore, if you were to intensify N3 sleep, okay, would that also lead to increased growth hormone release? So far we don't think so. So we're not increasing the duration of N3 sleep. Okay? It's still the same 20-25% that the baseline is. What we're changing is the intensity of the sleep. So we don't think so. However, there are certain things that are important. Okay? What I didn't allude to earlier, which I should have, was that N3 sleep is a closely linked to adenosine. Okay. Adenosine, which is what I showed you, sleep promoting, is what really is linked most closely to N3 sleep. It's the EEG biomarker of adenosine. And if we were to increase N3 sleep, is there a threshold wherein we can no longer increase it, which means that over time, with any agent that we use every day for N3 sleep, would that diminish over time, cause tolerance? We are not sure yet about that. We're not sure yet. There's one important study that you might want to look into, is using hypnosis. It was published about 3 months ago. There's a group of European investigators who used simple suggestion to the patient before a nap. Simple suggestion that they ought to have more N3 sleep. It increased the N3 sleep tremendously. Okay, so like I said, there are many things that we don't know about N3 sleep yet, but I think that's the frontier of sleep now. We've always thought about REM sleep because of sleep apnea, but the next frontier of sleep research would, I think, concentrate more on N3 sleep. Again, thank you.